think we'll go ahead and get ourselves started here so we can finish up on time. Dr. Ram is away, so I'm doing introductions today. So I am very proud to introduce Dr. Stobbe, he's talking about autism. And just for folks out here in the audience, he started his career as a psychologist in 1985, and actually has a BS in psychology from UCLA, which I think is very impressive, shows the sort of psychological bend. And then in 2003 and 2009, before joining the UW faculty, he actually ran the Autism Spectrum Treatment and Research Center here, the A-STAR here in Seattle. And after joining the UW in 2008, 2009 became the medical director of the Seattle Children's Autism Center. And then in 2012 started the Adult Autism Center and Clinic here at UW. So he's going to be speaking to us about adult autism. Welcome.
Thank you. All right. Hello, everybody. So I did an undergraduate in psychology. I'd like to say I was a psychologist. I'd like to say I'm a psychiatrist. I'm not a psychiatrist either. So I'm always intimidated when I come and talk to you guys. I'm a neurologist by training. Did my residency down at UCLA, which is where I first developed interest in autism spectrum disorders. And one of the lessons today, we're encouraging increased comfort level for adult providers to work with individuals with autism spectrum disorders. And one of the messages is if I can do it, anybody can do it. So as psychiatrists, there's a big need, and we're really seeing this. And I'll kind of go over that a little bit as we go through our presentation. A couple of goals that we're gonna hit on, some basic things, just kind of going over our background of diagnosis, but focused on trajectory and outcomes as we think about our adults with autism spectrum disorders, and then getting into what your role might be as a psychiatrist in interacting with these individuals, focusing on some of the co-occurrences, the comorbidities that occur in this population, and then some pearls of wisdom on psychopharmacology. There's not a lot of literature in the data, so we have to rely on our pearls of wisdom. So you guys may have seen this. This is always hits the press pretty hard with regards to our current prevalence numbers, most recently released a couple weeks ago from a CDC study, 1 in 68. When I was to date myself, I'm entering my 21st year of practice here in Washington. So I was in residency at UCLA in the early 90s. Anybody remember what the prevalence was in the early 90s of autism spectrum disorders? So 1 in 10,000. So quite a difference. Now remember our prevalence and incidence. So this is impacted by our diagnostic criteria, our awareness, capturing more patients. So we know those factors are influencing these numbers. The question still exists is whether there's a true epidemic occurring. Some factor in the environment is to be determined. With these numbers, we see obviously a number of individuals that are aging into adulthood in the U.S. and globally. And what we're also seeing is this real difficult time that these individuals, when they enter adulthood, what they experience. So much of what they rely upon is their school program. Their school program is the core of their treatment, and it ends at age 21 for individuals with disabilities. And but they're not done learning, and they need support, and the support is not existing there. So the traditional transition of a young adult from education to vocation has been very challenging. You also have the traditional transition of dependence with your parents to independence, and that transitioning into an independent state is very challenging for this population, both from the parents' perspective and from the individual's perspective. And then, of course, we have the transition of healthcare. We are transitioning from the pediatric world into the adult world, both medically and from a mental health standpoint. So all of these things hitting at one time, it really creates a difficult time for these individuals and the families. We opened, as mentioned, we opened our adult autism clinic with UW Medicine, opened up in September of 2012. We have I think at the time we had a whopping 0.15 FTE serving in the clinic. We don't have much more of that at this point either. But we see the numbers we've seen over, now by this point, over 400 plus unique patients going up on 1,000 visits. And you see the curve is going up as expected. Over at Seattle Children's Autism Center, this year we will have over 17,000 patient visits. So you will be working with these individuals, and we're needing this help, and this is what we're seeing is we're needing this support. The type of new patient that we're seeing in our clinic can kind of categorize into 3 groups. So there's the ideal group, which is this nice handoff of the baton from the pediatric provider into the adult world. Individuals that have gone through kind of coaching and case management about transition while an adolescent, working with the families, getting them to understand, how this transition needs to occur. Those patients come over pretty nicely. Most of those patients are pretty stable. The second group are the drifters, the ones that where the baton was dropped, and these are individuals that kind of drift into adulthood, not having the connection with necessary services. And what we're seeing in that group is relatively high, and we're working on getting a better understanding of this and doing some chart reviews to categorize the numbers on this, but a relatively high frequency of mental health crises in this group, both in individuals that are significantly affected as well as the high functioning population. And we think this is because of the lack of support, the lack of connection with the community, the lack of the difficulty in them continuing their education and moving into the workforce, all of these reasons. Their stress at home is getting higher. The relationship with their parents is becoming strained. These are adults. They want to be adults, yet they don't have all of their adult skills. The parents want them to be adults. The parents are burned out, yet the parents are serving as the primary case manager in most of these cases, and that seems to only last for a certain period of time. The third group is also an interesting group. It's the undiagnosed, looking for a diagnosis. So I think that with autism in the press, a lot of individuals that are looking in the mirror, asking the question, well, maybe I have high functioning autism spectrum disorder. And so those are interesting evaluations, and really difficult for us with our current staff at the clinic because we don't have psychology. So we don't have the ability to do a full psychological assessment. Most of these individuals have numerous mental health diagnoses that have been attached to them over the years, some of which may be accurate, some maybe not. Maybe the diagnosis was missed. But those are challenging cases for us. Most of those, I'm not feeling capable looking just at DSM-5 and making a diagnosis in those individuals. I usually don't have a very reliable early developmental history, and without that early developmental history and without a full psychological assessment, the diagnosis is challenging. This is my first slide, and this slide are by Forrest Sargent. Forrest is some of you may know Forrest. So Forrest is a early 20s now, severely impacted nonverbal individual with autism, severe stereotypies, repetitive motor mannerisms, and his parents discovered his ability that he actually did have literacy skills even though he could not speak. So he's one of these individuals that was able to communicate without speaking. He uses a pencil, and you hold a stencil board with letters, and he will stab out the letters and spell words. And when he didn't discover this until after about 3 admissions to the IPU at Children's. for severe behavioral disturbances. Once his communication method was discovered, he has not had those severe behavioral outbursts since then, although he remains severely autistic. The first thing he asked me when on his stencil board is, am I getting better? He spelled that out, and he spelled out, I want to be a photographer as well. So his parents have got him a camera. They have to go through a lot of editing because his movements are so significant. But he does name the pictures. So his name, Rock Alone, on this photo. So as a reminder, we went through our transition from DSM-4 to DSM-5. So just a reminder of DSM-4 criteria for autism. We remember it was in the group of pervasive developmental disorders and required 3 areas of impairment. Impairment in social, language and communication impairment, and the repetitive behaviors and restricted interests. You had to have deficits beginning prior to age 3. And we had the 3 main subcategories: autistic disorder, Asperger's disorder, and PDD-NOS. And in DSM-5, we saw the social and communication meld into one. So we have social communication deficits along with the repetitive behaviors and restricted interests. We recognize the higher functioning individuals often aren't observed until they're around other children. So the requirement of age 3 is removed, and it's you can pick up symptoms in childhood. And the subcategories have gone away. It's been whitewashed. Those in the clinic working with these individuals were very appreciative of that. The one group that wasn't appreciative are the Aspies, the individuals that look at this as an identity, and those individuals were upset with this. And so we still use the term Asperger's disorder, but when we're coding, we're just coding autism spectrum disorder. There were some interesting studies that contributed to that. A large multi-center genetics study in which to enter the study, you had to go through a very formulaic diagnostic process. Everybody that was doing the diagnostic evals were trained with the same system, multiple centers of excellence through the United States. They went and looked at the groups from the different centers and realized some sites 100% were diagnosed with autistic disorder, other sites 80% were PDD-NOS. They looked at the criteria to see are there actually differences geographically, and no, they were the exact same patients. It was where you were trained, what state you were in, what the services were depending upon the diagnosis. So all these other factors. And so I think that erasing those subcategories was very appropriate. So one of the things that getting into the adult group, the question of trajectory. There's not a lot of good data in the literature on outcome. There are a couple of studies that are prospective. They're just getting to the age of where the individuals are in the 21 to 25 age group that's getting categorized. But we can look at a few studies, and I think I can simplify it in some basic numbers and say that we have about 1 out of 5, about 20%, that follow a pattern of what we call optimal outcome. So that term has been coined. And optimal outcome, you can think of an individual that met criteria for ASD at age 3 to 4, and you look at them at age 18, and if you put your blinders on and disregard their early development, they no longer meet criteria for autism. Now, they may have symptoms of anxiety, they may be quirky, they may go to medical school or work at Microsoft, but they no longer meet criteria for autism spectrum disorder. Now, you have a similar number that is a not so good outcome. So there's also about 1 out of 5 that remain severely impacted. Those are the individuals that are going to continue to need 24/7 support throughout their life. Many of those individuals are the low communicators, the non-verbal population. The majority, the bulk, make progress, still have autism spectrum disorder, but make progress. And a really important point of this is the progress doesn't stop when they turn 18 to 21. The progress continues on. Been very impressed by the progress from age 20 to 30 in this population when we have that ongoing support in place and when we manage their mental health issues and these other factors that can result in them ending up in the ditch if we don't take care of them. So this is a really important message, and it's an important message to transfer to the patients, to the patients' families, at an age where we have determined kind of what track they're on, and we're pretty good at estimating track by age 10 to 12 for these kids. You can tell a kid that certainly is maybe you're kind of rough in that middle, but you can eliminate that optimal outcome for some, or you can eliminate the poor outcome for some by that age, and that's very important. You can imagine for a parent to plan. You know, am I planning for my child to go to community college and go on to get a degree and have a job, or am I planning to be a guardian of this individual through their adult life? So that's very different than when they're 3, and basically everybody gets early intervention, everybody gets speech therapy and occupational therapy. So what is needed then is determined by this. And so we do a lot of counseling in our teen years, our adolescent, to transition towards adulthood about this concept. So we're talking about improvements. Really, improvements have been shown across the board in some of our core features. I mean, we've got some of our core deficits, the repetitive behaviors, the stereotyped interests, social and communication deficits have been shown to continue to improve in adulthood. And some of these more severe behaviors, the aggression, the self-injury, also improving. You know, it's really fun for me sometimes to, as I'm dealing with some struggles of a 23-year-old, to remind the parent, go back and look at think about how they were when they were 13. Like, okay, yeah, you're right. We're still making progress, so that's good. So what are the factors? Are there factors that influence the outcome? And I've kind of divided them by the concept of intrinsic versus extrinsic factors. And one of the big ones that's not part of the diagnostic criteria is their cognitive ability. So do they, with or without intellectual disability, which is now in DSM-5 is a moderator to the diagnosis, okay? Because it is such a big independent variable. The core deficits, the core autism deficits, you can imagine an individual, the biggest one being do they have the ability to communicate? Are they verbal? But also the social deficit and the restricted interests. You can have some individuals that are high functioning with their communication ability, but they're so hyperfixated on one topic that it is really interfering with their ability to function in society. Separate from those, you have these aberrant behaviors. So if you have an individual that is a spitter or a hitter, you can imagine how that specific variable influences their outcome. The comorbidities, which we'll be spending time going over, do they have depression, anxiety? Do they have medical comorbidities like epilepsy or sleep disorder? So these are factors that will influence their outcome. The biggest one that we try to focus on that we can do something about, in addition to treating the mental health comorbidities, is the case management. This concept of how are we supporting them? What is their fuel still in the system to keep these individuals going? Access to services, absolutely. We'll see this with families that have insurance that covers services like, the intense behavioral services are covered by some companies that are self-insured, and access, where they live, and are they in an area that has access to services? So these are variables that also do appear to impact outcome. Just a little on gender differences as impacting outcome. So idiopathic females, and I'll talk about idiopathic versus syndromic in a little bit, but females that do not have other underlying syndromes tend to have less eccentric interests than males. My Little Pony versus urinals tends to, so an interest that is a little more socially appropriate tends to do better with developing social relations and impact the outcome. They also, females appear to have more social interest than boys, but their social cognition is poor, so they don't have necessarily so good social skills, but they have the interest to interact socially. Now, the trouble with that, though, is when they do become self-aware, as their theory of mind kicks in and they start to become aware of their differences from others, the age that happens, especially in these high-functioning girls, is often at, what age? 5th, 6th, 7th grade. Is there a crueler group of people on the planet than 6th grade girls? So I mean, it's a tough social environment. So even though relative to boys they may be higher, but relative to their peers, there's a bigger drop-off, and so they are at risk. And these the girls are even at more of a risk for anxiety and mood disorders as a result of that. They are harder to pick up, though, because of their interests, because they have the social interests, and because their hyper-focused area of interests are more appropriate. There's often a delay in diagnosis for girls. So let's talk a little bit about the neurological and medical comorbidities. This was a piece of art by Guy McDonnell. Guy passed away last year from a seizure in his sleep. He had some great art that was displayed in a number of studios through Seattle through the years. So coming back to the concept of idiopathic and syndromic, so that term has been coined to syndromic to represent individuals that have an underlying disorder in which autism is a symptom of the disorder. So this is another group that's partly responsible for the increase in prevalence. So back when some of us were trained, the developmental pediatricians would not have given an autism diagnosis to a child with Down syndrome. They would have said Downs with autistic features. But what we recognize is that a child that has Downs that has autism is very different than a child with Downs that does not have autism. And the technique of education for that individual needs to be very different, how you educate those children. And parents of kids with Downs that have autism connect much more with other parents with autism than other parents with Downs because of the social deficits and the lack of social interest in some of these children. So it was good to recognize that these other syndromes can have autism as a feature of their neurodevelopmental delay. The male-female ratio in that syndromic group is 1-to-1. Okay, so even though you have, when you're a high-functioning girl, you're in good shape. If you're a girl, by odds, you have to be careful because you might be coming from the syndromic group. And this is something that we teach to our pediatric residents, that when they're doing these evaluations, when do you send to the psychologist for an autism evaluation? When do you send to the neurologist or the geneticist for a more formal metabolic workup? And so when we see these other features like motor delay, dysmorphic features on exam, epilepsy at the onset of the time of diagnosis, especially if it's a girl that's got some of these features, we don't want to just do an autism evaluation with a psychologist or a speech therapist. We want to do a medical evaluation with those children. And this is something we were interested in is in the adult population then, we were looking back and we were asking the question of, well, gosh, have we done genetic testing? When did you have genetic testing on your severely affected 20-year-old? And, oh, yeah, we had genetic testing. We had Fragile X and chromosomal karyotyping 15 years ago. So it did not have any modern genetic testing. And so we did a series, we published this last year, a series of patients, and we were getting a high yield of genetic abnormalities. We believe this is because it's an enriched population. We were sending individuals, the 20-year-olds, like this guy's got dysmorphic features, he hasn't had testing done, let's send him for retesting. And sometimes you come up with actual syndromes, and this is very useful because you identify other medical comorbidities, and for the parents, it's really beneficial for them to have a better understanding of what to expect with their adult children. lots of research going on in the genetics of autism. You know, there's a lot of risk genes, and this is an ongoing, involving field that hopefully we're just starting to see glimpses of things coming back from the bench that are going to hopefully lead us to some more designer therapies. And that would be ultimately the other reason to identify these genetic syndromes as potentially targeted therapies in the future. Just talk briefly on epilepsy. So epilepsy is common in this population. Upwards of 20% of adults have epilepsy as a comorbidity. This is, again, all types of seizures. Typically more are EEGs that are focal in nature. Again, if you see seizures that begin at the time of diagnosis, beware of a syndrome versus a later age of onset. If we look at this study from Bolton in 2011, looking at age of onset in years for epilepsy and autism, you can see that this can occur out in adulthood. So we have to be careful of, you know, again, the individual that comes in with some regression in behavior or function. On your differential is the possibility of seizures, especially if you've got complex partial seizures that are, you can imagine how difficult it would be to recognize a complex partial seizure in an individual that is severely affected, that has stereotypies and other unusual behaviors. The other medical condition to talk about is sleep. Sleep appears to be specifically elevated in this population, and it appears that there are some genetic syndromes in which severe insomnia and sleep disruption is prominent. And this can be a very impactful disorder for families, you know, if this persists. And it does appear to be more, as I said, more than other developmental disorders. And the third medical thing to think about is metabolic disorders. Specifically, mitochondrial disorders are of particular interest. I think when you're looking again for dysmorphic features, you're looking for other systems involved, GI symptoms, skin abnormalities, abnormalities on labs. And this is again the group where we would potentially do blood work and imaging. You know, if we see an individual that has recurrent regression, has seizures at onset, or other systems involved, thinking about doing this additional medical workup. Okay. So let's talk about, so we talked about medical comorbidities and neurological. Let's talk about psychiatric comorbidities. These are hand-drawn sketches from Josh Perkins. Josh just recently graduated from Seattle Art Institute, high-functioning Asperger's. I love the eyes that he has on some of these, pretty cool. So we'll kind of whip through a lot of these, but and again, the literature for adults with these comorbidities does not have a lot in it at this current point. So a lot of what we're gaining is through our experience again. Some general considerations about comorbidities is really the general concept that ASD is a neural developmental substrate of a human that can have psychiatric illness, can have mental health illness. Okay, in fact, they are of higher risk. You know, and so we've been dealing with this with some of our community mental health clinics that are saying, well, we don't treat autism. And we say, well, we're not asking you to treat their autism. We're asking you to treat their depression, their anxiety. You know, would you treat a patient that has cancer or multiple sclerosis that we send to you that has depression? We're not asking you to treat their MS. So this is something that we're continuing to battle. The other concept, basic concept, is the manifestation of the mental health illness can be very different than what, you know, these are, especially if you're talking about, well, really high functioning and low functioning. These are individuals that have difficulty recognizing their own feelings, recognizing their own emotions. They have difficulty in describing it to you. So even in the high-functioning individuals, your normal technique of gaining this information may be challenging. And you can imagine in low communicators how difficult it is. And if I'm 25 and I'm a nonverbal individual with autism and I've been out of school for 4 years and I don't have anything to do, how am I going to manifest with my depression? I might manifest by throwing bottles through windows. I mean, so those are things again. So the question of the changes in behavior, a new onset or worsening of a mental health diagnosis is right there at the top of your differential. Also, the overlap of the features of these mental health conditions with ASD features, and this is in the early years. This will often hide the ASD. So individuals will get diagnosed with ADHD, they'll get diagnosed with childhood bipolar, and then look at it more. It's like, well, this is actually an autism spectrum disorder. In adults, it's the reverse. Everything's blamed on the autism. Well, that's his autism. That behavior is his autism. It's like, well, but he wasn't doing that a year ago. Something's different. What's going on? So that's a really important message. So ADHD, can be present in this population from a very early age. Again, kind of difficult to differentiate from features of autism, and this remains true. And I think I've struggled with differentiating features of ADHD from some autism features, even in some of the adults. You get a high concordance of meeting ADHD criteria, but I think some of those individuals have autism and don't have ADHD, and really to be able to really differentiate, how do you do it? So we will do trials of medications, and we have to explain to the parents that this has a good chance it's not going to work, but thankfully, the treatments are safe, and so we can do those trials. The neuropsych testing can maybe be useful. The tendency for impulsive answering of questions is classic in the ADHD population. In the autism population, processing speed deficits are very prominent in this population. They might have, if you look at their IQ scores, they might have really high verbal and even nonverbal. They might both be high, maybe a discrepancy between the two, but their processing speed will be down at like 70 or 80 or 85. And it's that processing speed deficit that seems to really interfere sometimes with their success in both the school and in the work environment. Anxiety and depression. Anxiety, probably the most common thing that we see in this population, and again can manifest in many different ways. The individuals with higher functioning forms of autism are even more susceptible to mood disorders than, we believe, than individuals that are lower functioning. We think some of this could be related to their greater self-awareness of differences, and also the challenges that we place them. They are in at times, more challenging social environments. Another difficulty, though, in differentiating depression is the lack of motivation that we see, especially in the teens and early 20s. They're motivated for what they're interested in. So they're motivated for their video games, and they're motivated for their specific area of interest. Try to get them motivated to do homework. Try to get them motivated to do other things. And that's not necessarily depression, although it can look like it. So differentiating that can be difficult at times. Psychosis in adults, certainly the relationship with schizophrenia is very interesting and controversial, and I think that studies have been, to me, unclear as to is there an increased risk for schizophrenia. There's certainly an increased risk for psychosis in this population, but the belief is usually the psychosis is related to a mood disorder, more typically. This is, again, if you see emergence of psychosis in this population, asking the question of have they had genetic testing, because there are some specific genetic syndromes that have an increased likelihood of onset of delusions, hallucinations, the same age that you would see schizophrenia emerge. This is a really interesting and evolving topic, the topic of catatonia in this population. Elevated to a modifier in DSM-5 with or without catatonia. Recognition of catatonia in this population, again, direct overlap of symptoms of catatonia with core deficits in ASD. Stereotypies, echolalia, mutism. Again, the issue has to be the issue of change in this population. And you're going to see it in the teens and young adults is when you're going to see this. And, have I ever taken a patient to ECT? No, I haven't. Maybe I should be. And so this is a big. We're just kind of starting this debate. Are we needing to be more aggressive? Interesting research emerging from some animal models with regards to benzodiazepines. Again, how that relates to this population and the use of benzodiazepines are I think we're going to be seeing some evolution of that process over time. I'm not going to get into, you guys know this stuff way better than I do with regards to bipolar. I think the concept of childhood bipolar and those are a lot of times some of the kids, these high functioning kids that will have been diagnosed by a psychiatrist as having childhood bipolar who meets criteria for autism spectrum disorder. Now, again, you can have both, and I think you've got these other options in DSM-5 to explain episodic disruptive behaviors, potentially again superimposed on an autism spectrum diagnosis. And I think the question that we're grappling with is, when do we raise it to the point of actually considering it a comorbid diagnosis as opposed to just a part of their ASD? When you have is it a specific behavior that is just a repeated behavior, or is it a behavior that is so disruptive that it deserves a special label and attention and treatment? There's certainly evidence in the literature and in the clinic of overlap with obsessive-compulsive disorder, and we definitely see individuals that will have compulsive behaviors that will emerge in teens and young adults. They tend to be individuals that have lots of stereotypies and lots of movement abnormalities. So again, it can be difficult to recognize, but the question of a new behavior, and this is again the point of, and so we'll see these individuals that are having to touch everything before, can't go through a doorway, and this will emerge as a new behavior. Motor tic is also elevated in this population. Again, tends to be in individuals that have more motor stereotypies. So again, challenging with regards to identifying something as a tic as opposed to a repetitive behavior of autism. And again, emergence of a new behavior and really trying to identify, how the motor mannerism occurs. Does it have this very sharp phase to it? And often will increase in periods of anxiety versus stereotypies that they can increase in anxiety, but they tend to just increase with fun and excitement, versus a tic that's going to tend to be more driven by anxiety. Put personality disorder up here just as a reminder. This is an interesting concept. Can an individual with autism spectrum disorder have a personality disorder? I suppose, why not? But I think the thing there is in evaluating an individual and putting in your differential of a personality disorder, the importance of a developmental history. And I think the question of, is their personality disorder stemming to a neurodevelopmental disorder that would warrant a categorization of an autism spectrum disorder? So we'll talk for a few minutes on some of the specific medications that we use in the clinic. This is Party Boy by Will Kerner. Will is just turned 18. Will cuts out paper construction paper, puts it together on the table, And if his grandmother's quick enough, she comes and takes a picture of it before he messes it up. And then she takes it and goes and puts it back together based on the picture. This piece actually sold for about $15,000. So he's at least funding his, and he's has severe autism. So go to his website. He's got some really cool pieces. So so some general lessons on psychopharmacology. Once again, evidence in the literature is lacking. We have two meds that are FDA approved for autism in children, those being risperidone and aripiprazole. The classes that we most commonly use, anti-psychotics, the SSRIs, and the stimulants. There's a trend towards the older the individual, the more likely they're going to be on medications, the more likely they're going to be on polypharmacy. I don't know if that's just, again, a statement to the lack of support that we have and other elements in our society for these individuals. Polypharmacy, very, very common. So it's challenging for our non-mental health providers, our primary care providers to manage these individuals. So what can we learn from child psychiatry? So in preparation for this talk, I did a little survey with my 6 psychiatrists and 2 psych ARNPs at the Children's Autism Center. And they all answered, which I was pretty happy with. So I asked them 3 questions. I asked, name your 3 most common meds that you use. What do you find most challenging about pharmacotherapy and ASD? And what advice would you give your adult colleagues when working with individuals with ASD? So the first question, it was nice to see that they use the meds that are used elsewhere. And interestingly, so we had a few alpha agonists, guanfacine and clonidine, that were in the top 3. We don't see anything else that came up in the top 3 of all of these providers. So that's at least simplifies things for us a little bit. Here, these providers are working with teens, working with adults, certainly 18 to 21-year-old group at Children's as well. And I think you see that, which one from which class? Is there one that's better than the other? Certainly we don't have evidence in the literature of that. And, so again, it gets to getting comfortable with your go-to medications that you use, I think is the overriding rule. So sorry, this is probably too small to read. I think that, and a few people couldn't only give one answer, they had to give like 2 answers. So I went ahead and threw up those answers as well. So, but the most challenging aspects kind of went into 3 categories. The first category was identifying target symptoms. So we talked about this again, that, how do you know that a specific symptom represents anxiety? Or how do you know maybe it represents ADHD? It's totally different. And one person commented, multiple symptom clusters occurring simultaneously in the individual. And really difficult then to try to coach. You've got this parent or the individual that you've got to coach on, here's my target, here's the expectation. Okay, we're targeting this particular behavior and getting that coaching done before you start the medication. And then, of course, what are we relying on? And this is true of psychiatry in general. How are we doing? So pretty subjective outcomes. We have certain situations where we can rely on other reporters. If individuals are in school, or we can rely on, if they're working with a counselor, or if they're attending school or at a job place. So, but most time it's the parent or the caregiver or the individual. The second group, the response, highly variable in this population. I think we have a greater likelihood of adverse events and a lower likelihood of a good outcome with treatment. So our expectations going in just have to recognize that you're not going to hit a home run as often as you might with other populations. And the third question, what advice would you give your adult colleagues? So a lot of advice focused on really before starting the medication. So get multiple sources of information, identify the specific target symptoms. Remember that you're targeting comorbidities in the context of ASD. Focusing on most debilitating symptom. Always remember anxiety. Anxiety being kind of the most common driver. And make sure you're optimizing non-medication treatments before to support the medications. After starting, start low and go slow is definitely the rule with this population. Start lower than what you would typically start with an ADHD patient or another patient with anxiety. Do best to avoid polypharmacy. Have the expectation of seeing symptomatic and developmental improvement over time. So is the benefit from the medication or is the benefit from some other reason? And remember, as a psychiatrist working with this population, you'll be judged less on whether you get it right the first time and more that you remain invested and willing to try to get it right on the second or third, or however tries it ultimately takes. So that was our chairman at Children's. That was Brian King that threw that one. So I get to reveal that part. Just additional pearls on this. Just new aberrant behavior may be a response to physical symptoms. So again, remember that as well. So the individual that's nonverbal, that hasn't gone to the dentist in 5 years. So you have to. Those things are also on your differential. The end game of everything may be agitation. Side effects of medication too. How does an individual relay that they might be dizzy from a medication? It might be through agitation. So, and working with this population, I think that especially with individuals that are low communicators, I try to teach the residents to kind of approach as if you were doing an evaluation. Somebody else that was a low communicator, like let's say you're doing an evaluation in an ICU of a patient that's in coma. How do you know they can't hear you? How do you know they can't understand what you're saying? You'll develop a much better rapport and relationship if you take this approach of don't exclude them in the conversation. So yes, you as the parent may be the guardian of this individual, and obviously, you're doing most of the, but don't exclude the individual with autism that's sitting right next to them. Again, you'll be pleasantly surprised by the response that you get from the individual with autism when you treat them that way. And the parents or the caregiver are used to going in through society with these individuals as kind of second citizens. And so if you treat them with respect, you're going to have a much better relationship with those families. I'll whip through just specific meds real quick. Just comments on the ADHD meds. Long-acting agents tend to be better tolerated. Just a shout out for amantadine as an option to think about in this population. Seems to be well tolerated and will sometimes work. The SSRIs, just be cautious about possibility of hypomania in this population. We didn't see the mood stabilizers on our list of 3 most common, but certainly we do use mood stabilizers in this population. As I kind of intonated on, the landscape is changing with the anxiolytics. The pendulum swung away from these medications because they were overused, used to just try to sedate and knock these individuals out. But we actually are seeing that there is a role for, especially for low dose benzodiazepines for some of these individuals, and some animal studies potentially suggesting that, supporting that possibility, and just beware of zolpidem for your sleep. In this one animal study, it worsened the autism behavior. Most studies of risperidone and aripiprazole. Certainly, the psychiatrists at the Autism Center use all of our antipsychotics, just with less frequency than these two. We're targeting self-injury, aggression, impulsive behaviors, but we see other benefits with these medications. Certainly for tics, you can certainly see them in mood. Again, mood with psychotic features, obviously. And just a comment on emerging therapies, a study from Stanford on N-acetylcysteine, or NAC, Studies that are ongoing with memantine, looking at irritability and communication, and then the excitement of oxytocin and vasopressin. And we're involved through Seattle Children's Research Institute study of intranasal oxytocin, both for pediatric population, and we have a study of a vasopressin antagonist in adults. And we're just started enrolling in both of those studies, and look very promising. Some promising data, so that's exciting. All right, I think that's it. This is Dumpling. So, all right, so let me look and see if there's any questions on. Okay, so any questions from the audience? Yes.
So the studies on oxytocin and vasopressin, what is your outcome that you're looking for? Better communication or?
Yeah, social interaction as the kind of the primary, but also some irritability measures. They are still kind of a lot of exploration with regards to outcomes. So the primary outcomes are in the area of social communication, so which is great because now we're really targeting core deficit, which is exciting. But then they've got all kinds of secondary measures that they're doing as well. So, yeah.
Can you touch again on the distinction between ASD as a syndrome versus when it is what we can say now as
So the question of ASD as a syndrome in and of itself versus a symptom of an underlying condition. I think that probably in our idiopathic group, there's underlying syndromes that we just haven't identified. So I think that we are going to have some kids that look dysmorphic, motor delay, where it's like, boy, this looks like there's an underlying condition in addition, that's even greater than just their autism diagnosis. We'll do testing on those kids, and we don't find anything. Should I consider that kid a idiopathic, or should I continue to keep that kid in the syndromic category? It doesn't really matter that much. I mean, I think that it's more about a framework for you as a clinician to understand that when you have individuals that have these other larger syndromes, you have to be careful that they're going to be more likely to have some of these other medical illnesses, some of these other neurological conditions. And so, keeping an eye on those sort of things is important. Good. Any other questions? Yes.
So, someone who's not in crisis, but still has, of course, symptoms of autism, how aggressively do you treat the medications? Or would you just say, well, how much does this impact your life? Right. So the question of how often do we use medications when we're not identifying these other comorbidities? I mean, I think that I'll see a lot of variability, in approach with medications in that population. So we will see certainly some providers that are targeting, core deficits with medications. And the argument we will see cases and examples of cases where we introduce an ADHD medication and all of a sudden their social ability is improved significantly because they can stay in a conversation for a longer period of time, stay connected to that conversation. They can do better in school. Their distractibility is improved. And I think, again, because there's so much overlap, it's really hard to judge sometimes. I think especially with ADHD. But also in childhood, I think the evidence, there's some evidence supporting this trend, the development of anxiety and mood disorders in these individuals that if you wait too long to treat. So there is some evidence supporting that concept. But then you'll have other providers that it's like we're going to stay away from medications as long as possible. And unless we start to see something superimposed. Yes?
I want to ask about the priority of the med list, because the one that's, I think, the most problematic for me when I'm reviewing cases on the inpatient unit here are the psychostimulants. And I guess my question is really, you had another, I think the second slide on that survey was about picking your target symptom, about what's most problematic. And it seems to me that we see patients who start off as outpatients where communication and other things may have been the target. It's a psychostimulant, and now we have them on the inpatient psych unit detained because of violent aggressive behavior.
Right.
With what looks to be psychosis, when
Right.
stimulants would be probably the last thing
Yeah.
we would really want to do.
Right. Right. Yeah, I think we do the same thing in the outpatient clinic when we're taking over patients' care. I think we are probably more often removing meds before adding. And I think that, in the inpatient, it's challenging because you've got this window, right? And so, again, to me, it makes sense sometimes to, let's remove this and let's see what this looks like without. Because it's really hard to judge. But it is good to recognize, though, that we have seen, again, that these medications, sometimes if you go back and you look at history and you say, wow, this guy's never been tried, so that's different than an individual that's on them already, right? Individual that's on that. I think you get the individual that comes into the inpatient that's never been tried on that. It's just, again, it's something that you could consider. You're going to get a pretty quick response and answer. So it is one of those things that you could potentially try, inpatient setting. I think that is challenging. I think this question about, catatonia and how that is emerging in these patients and how aggressive should we be with these benzo trials as inpatient, I think is something we need to discuss and maybe come up with a protocol and approach. So, yeah, yes.
One of your slides mentioned sleep, and what was the frequency of sleep problems, and elaborate on the melatonin study?
Yeah, so so the question of sleep is there is some research that has supported that individuals with autism, children with autism spectrum disorder, do not produce melatonin as well as other individuals. So I think that has been shown in some studies, and so I think melatonin is kind of our go-to first line treatment in this population. Also, some interesting, some of these individuals with very severe sleep disorder. There's one of the genetic syndromes, Smith-Magenis. There's a protocol now that's been developed, melatonin inversion protocol, in which you give a beta blocker first thing in the morning to suppress production, and then you give melatonin in the evening to try to get this rhythm. And there's been some data in that population that has worked very effectively. And so we've started to explore that actually in non-Smith-Magenis patients that have severe sleep disorders, and especially if sleep disorders that stem from a very early age. I think that's an important question about their sleep. How long has the sleep? Now, the parents, the answer is usually they've always had it and they never sleep. You got to try to get them to be a little more specific and not quite as dramatic, to get an understanding. But
And they never get outside, and they're on the computer.
well, yeah, exactly. And so that's also part of our protocol. The sleep hygiene, for this population is huge. Getting physical activity, getting outside exposure, no lights in their room when they're sleeping. You really have to go through that sleep hygiene stuff with these guys. Yeah. And that still is tough. So, often this population, these parents have, they can only pick so many battles, right? So often, the kid that only eats French fries. Well, maybe if you didn't only feed him French fries, he wouldn't only eat French fries. But that wasn't at the time, that wasn't a battle they could take on. But then later on, there's regret, about that. And so that again is something, us teaching these adaptive skills in the pediatric clinic is huge, because otherwise we pay the price in the adult clinic with some of these behaviors that are, supported through the years. Yeah.
I was just going to ask, what was the problem with Zolpidem?
So in this one animal study, because it targets different subreceptors on GABA, they showed that it aggravated the autism behaviors in the animals versus some of the other benzodiazepines. So there's this question about how you're activating GABA. So this is actually from the guys here from Catterall's lab. They published that in Neuron just this year.
Have you found that with actual patients?
I don't, it's interesting because I can't say I use Zolpidem. I don't know if I got burned and I'm just forgetting it. So it made me think about it. I was like, oh, I really don't use that in this population, hardly at all. So, yeah. Yes.
Also, you didn't mention the mood stabilizers at all.
Right. So they didn't fall on our list, but it's good to, yeah, we definitely use the mood stabilizers. I think, so my bias is, as my training as a neurologist, is I end up using the anti-epileptic drugs, more commonly. But there's good efficacy with lithium, in this population. And so I think that you can feel comfortable. I don't know, Dale, if you have any thoughts on that.
Well, I mean, it's getting the blood draws are a problem. You have individuals who don't tolerate.
That's a
blood
great
draws.
point.
Are you going to put them on lithium or is that
That's a great point. And you also have to look at their other health issues, so the weight is a big problem with this population. And so as much as valproic acid is effective, I hardly ever start it anymore because often these guys are on, risperidone already, so we're tending to choose weight neutral meds that do not require monitoring as our frontline agents, even though they might not. So lamotrigine, would often be a medication we might go to. Oxcarbazepine would be one. Yeah. Okay, you guys probably have to go see patients or something. So thank you very much.